Hello, it's Adam again, and today we're going to be doing our test 3 review. Sorry it's coming up a little bit later than normal for these Thursday videos, but I was actually getting several questions in, so I wanted to leave the time open a little bit longer for people to get those in. So anyway, here's the video, and we'll go over some questions you guys had, along with some of the things I think are important concepts. Obviously, I will not be hitting on every single topic that was presented on during the lectures, but certainly if you have more questions before the test, feel free to send them my way, and I will try to get to them as best I can. Okay, so one of the first things we talked about was going to be the endocrine section. We talked a lot about some of the anti-diabetic medications. Obviously, kind of the best kind of the most natural treatment would be to simply replace the amount of insulin that someone is either not producing, especially if they're type 1 diabetic, or give them some extra exogenous insulin if they are particularly insulin resistant in the case of like a type 2 diabetic. I put this table up here, not necessarily so you guys memorize, exactly when the peaks and onset of action are for the different insulins, but it's good to know the difference between the various categories of insulins and kind of have a general idea of how quickly they work and how long they're going to be acting for. So, for instance, you have your ultra short acting, you have your short acting. Usually you'll end up seeing that mealtime insulins or insulin that you give throughout the day. Certainly sliding scale insulins where you are dosing the insulin based off of a patient's glucose measurement, in addition to how many carbohydrates they're ingesting. You'd be utilizing these ultra short or short acting insulins. Things like IV administration of insulin is usually going to be one of these regular insulin, so either Humulin or Novolin, just being two different brand names for that. Things you'd be giving less frequently throughout the day because they have a longer duration of action are going to be things like your NPH insulins, which are your intermediate duration of action insulins. Those are going to have a longer time to actually have an onset. So they're not good for dealing with, postprandial surges in glucose, but they are nice because they last longer throughout the day, so they can kind of help simulate more of that kind of basal insulin release that your pancreas normally would have. So the NPH ones would be dosed twice a day most often. And then you'd have some of your mixes there. You see like the 70-30 where they're actually mixing a regular or either short-acting or ultra-short-acting insulin, in addition to one of the longer-acting ones like an NPH. And then finally, you have your long-acting insulins like your Glargine or Detamir, where these are just going to be administered just once a day because they generally have a lot longer duration of action, around 24 hours or so. So again, here we have just a nice graph kind of showing you the way that the different insulins will have their duration of action and also their onset. So again, your ultra short acting, like your insulin Lispro, aspartaglucosamine will be very, very quick, very high peak of action. And then your short acting, like your regular insulins, again, will be fairly quick, nice postprandial influxes of glucose. And then you have your NPHs, which will have a less dramatic peak, but have a longer duration of action. And then your Detamir and Glargine, again, going to have very long durations of action without really having too much of a peak. So it's nice basal kind of action you'll have throughout the day. So again, looking at this graph, you'll see the different types of insulin administrations that you can see based on different types of insulin you're going to be using, along with where they are placed around the meal times. So again, looking at section A, you're going to see your normal plasma glucose concentrations. Obviously, the purple bars are going to be your meal times, and then you'll see kind of your stimulations or your fluctuations in glucose there. And then section B again is looking at the insulin release. So you can see obviously after a meal, blood glucose is going to spike up, and then your insulin is going to spike up shortly after that as your pancreas responds to that. So we end up having someone who is being treated, say, with a combination of regular insulin and NPH. So say they're on a combination product like a 70-30 product. You see they're only getting dosed twice a day, where the regular insulin will help to cover their breakfast, increasing glucose. You then have, by the time the lunchtime comes around, your intermediate acting insulin, your NPH, should be able to kind of kick in and be able to cover that lunchtime period. And then finally at nighttime, around dinner, you're going to be having another administration of the mix, and so then you'll end up having the dinner time period covered by the regular insulin, and then the NPH will kind of carry you throughout the night, just to be repeated again. And then with the Part D, this is the ultra-lente insulin is another kind of long-acting form, but more often you're going to see levemir or glargine being utilized most often as your long-acting insulin of choice. And here you can see someone who's on 3 times daily regular insulin along with a long-acting form that will help cover them for a 24-hour period. So most often you'll end up seeing like a sliding scale type of insulin administration where they'll have so many units based on the amount of carbohydrates they're taking in, and also how sensitive they are to insulin. Because you'll see patients will have different insulin sensitivity factors based on how they respond to insulin. Going into our other medications that are being utilized for especially type 2 diabetes, it's important to have a good distinction of their mechanisms of action, how they're specifically going to be working, and how they can be kind of synergistic with one another. So, kind of the idea of what would be good combinations of these medications to use, what doesn't really make sense for certain types of diabetics versus others. So again, looking at your kind of most commonly prescribed ones will be probably your sulfonylureas are going to be one of the big groups there. Again, they're going to be working by stimulating insulin release from the beta cells of the pancreas. This will be irregardless of meals time, which is a big difference between those and the glutamides. So this would be things like your nitegalenide and ropaglenide. Again, with those two, you end up seeing more insulin release in response to meals or when you have a big influx of glucose. Sulfonylureas are going to work irregardless of that. So again, those drugs, while effective, would not be effective for a type 1 diabetic because they don't have any insulin of their own to release, right? The next category of drugs are going to be drugs that sensitize the body to insulin or help to control the hepatic glucose production. So you have things like your thiazolidinediones, so it'd be things such as your pioglitazone, your rosiglitazone, that were able to kind of help with dealing with the body's control of the glucose, help to sensitize the body a little bit more to the insulin effects. And then your biguanides, of which metformin falls into this category. So. And then you'll have drugs that actually prevent the absorption of starches, so that would be things like your alpha-glucosidase inhibitors. Obviously, you guys remember the big side effects with those are going to be obviously a lot of flatulence and GI effects, mainly because, again, if you're not absorbing a lot of those carbohydrates, the bacteria in the gut are going to help to break those down and form CO2 and different other byproducts. So those would be kind of not all that too tolerable by the patients. It can be useful for patients who maybe have some other issues or pregnant patients, but certainly you'd want to avoid these in patients with things like inflammatory bowel disease, things like that. You wouldn't want to aggravate any more inflammation in the gut if that was already a problem for the patient. Big things to remember, forgot to mention on the biguanides, remember that renal function can take a big hit. We'll talk more about that later, but certainly having things like metformin on board whenever you're getting things like contrast or other nephrotoxins can be a big problem because if you have an acute kidney injury while taking metformin, you have a big spike in your serum creatinine, your GFR is going down, you're going to start to accumulate that, and eventually you're going to start to develop this lactic acidosis. So that can be one of the things that can be very, very dangerous with metformin, and so renal function is going to be a big contraindication if they have very severe dysfunction and cannot clear the drug appropriately. And then you have your incretins. These are, again, going to be working to help suppress things like glucagon, decrease gastric emptying, decrease food intake. So these are all going to help to help the body process glucose a little bit more effectively. May have some sensitizing effects as well, but it's also going to help to decrease the actual amount of food intake because, again, you're going to have better satiety from this, and so your drugs like your exenatides or Byettas will kind of fall into this category here. Again, just a little bit more detail about these incretins. Again, looking here, you can see that patients who have type 2 diabetes, especially, they're going to have more insulin resistance, but they're also going to have decreased amounts of these incretins being formulated, things like GLP-1. So if you can provide exogenous sources of this or things that help to increase the activity of the incretins that are being released, you can certainly have some kind of better effects on maintaining their normal blood glucose. Again, weight loss is going to be a common side effect you can see from this, which may be very effective for patients with type 2 diabetes who most often have obesity as a comorbid condition. So just a good thing to remember the different mechanisms between the different drugs and think how they can work in synergy versus which ones you wouldn't necessarily want to combine due to either lack of efficacy or not being appropriate for specific types of patients. And then we have the final category of medications for type 2 diabetics especially. I guess you could potentially get some use out of using for type 1 diabetic, but again, these are very new, and I'm very, very sure they don't have any data to necessarily support use in that group of patients. But these are your sodium glucose co-transporter inhibitors. Again, you can see the names of the drugs here. It's very, very new. Again, remember their mechanisms that they prevent the reabsorption of glucose within the kidneys. Thus, you're going to be able to basically filter out more glucose, not have it be reabsorbed, and just pee it right out. So again, you can see some beneficial effects for lowering blood glucose and also body weight. But please remember what some of the major side effects we're going to see with that, namely being fungal UTIs developing. So again, that's kind of a unique side effect for that one to be good to remember, especially if you have patients who are diabetics who are already kind of prone to having infections anyway. That can just kind of add more insult to injury in that circumstance. Moving on to some of our other varieties of endocrine topics. We talked a little bit about androgens. Just remember kind of your different varieties of androgens that are available, kind of what they're going to be utilized for. Big thing here, you're going to notice that most often testosterone and dihydrotestosterone are going to be kind of your most commonly used androgens, probably more testosterone than anything else. Again, remember DHT or dihydrotestosterone is kind of the more potent version, kind of a more potent androgen than testosterone because testosterone really gets converted over to DHT by the 5-alpha reductase enzymes. And remember, we'll talk probably more about in the urology section about 5-alpha reductase inhibitors, but we kind of mentioned those a little bit already. Certainly, there are synthetic varieties. You'll have things like methyltestosterone, roxandrolone. These are varieties that are able to be absorbed by mouth because, again, with testosterone, you don't get really a ton of good oral absorption or bioavailability with testosterone by itself. But if you're able to alter it, then you can actually allow it to have better bioavailability. But I will tell you that these are most often pretty hard on the liver. You can definitely see some increase in your LFTs and liver dysfunction associated with them. So they don't get a ton of use. So that's, again, why with testosterone, you're going to see a lot more transdermal use. You're going to see injections. You're going to see gels and topical use being used much more often than you will ever see oral androgens being given. Again, to kind of reiterate here a little bit what we said, you'll see certain depot products that are available as well. So certainly putting testosterone kind of an oil base will allow it to have kind of a delayed absorption from the intramuscular space. So that can help to decrease the number of times you have to administer the drug specifically. And again, transdermal is probably going to be very common dosage forms you'll see for this. So things like Androderm and Intestoderm are certainly out there. Just to look on kind of the flip side, so we'll see certain things have anti-androgen effects. Remember that you'll certainly with androgens being given, they'll have certain side effects associated with them. So certainly things like, especially in women, you'll see some masculinization, you'll see some hirsutism, you'll have deepening of the voice, definitely increase in acne and things like that. But remember that androgens also have positive effects on the bone, so they can actually help to inhibit osteoporosis. On the flip side, though, you'll have certain drugs that can either be things like androgen receptor antagonists, so things like flutamide or bicalutamide. You also have certain drugs that are going to have some mixed activity as well. So remember, spironolactone, typically used for things like CHF or hypertension. Again, because it has some anti-androgen receptor activity, you're going to see that things like gynecomastia are fairly common with that drug. And then you also have things like 5-alpha reductase inhibitors, which help to block that conversion from the less potent testosterone to the more potent dihydrotestosterone. We'll talk more about that when we get to the urology section. Just be aware of the different drugs and kind of what their different receptor activity might be. So one of the other big things we talked about, especially in regards to calcium homeostasis, phosphate homeostasis within the body, this is really important for especially chronic kidney disease or potentially patients who have liver disease, especially in regards to vitamin D. And then you'll also have your osteoporosis patients. This will be important for as well. Keep in mind that the main ways that the body is going to control calcium and phosphate homeostasis is going to be related to how much you ingest from the gut, because obviously if you have less being absorbed, more of it's going to be excreted in the waste. And then you also have calcium and phosphate that's already been absorbed into the systemic circulation that can be released from the kidneys as well. So you can have some degree of reabsorption depending on what the influences are. But those are the two main ways that calcium phosphate get in and out. And then you'll see also that the bone is kind of like the biggest depository for calcium especially. But based on the different influences from different hormones, you're going to see that at different situations, you're going to have different kind of shifts in the amount of calcium and phosphate being either intaken from the gut, excreted from the kidneys, or taken up or deposited back down into the bone, right? So the big things you're going to see here is that vitamin D, things like ergocalciferol, cholecalciferol, once they get activated, calcitriol, is the active form, you're going to see that that's going to have positive effects to increase absorption of calcium and phosphate from the gut. Okay, once that's there, you're going to see that things like vitamin D and also parathyroid hormone are going to have positive effects to not only resorb bone or take it up from its deposit there, but it's also going to influence laying down a new bone. So having that circulation of calcium and phosphate being kind of laid down and taken back up helps to increase the strength of the bones by having this kind of remineralization effect here. You'll see specifically, though, that in order to inhibit the effect of bone being resorbed, you have things like calcitonin. I'll show you just another slide in just a second that kind of talks a little bit more about that. Remember, calcitonin kind of puts a big inhibition or inhibitory type of effect on bringing up new bone from there. Once it's in the serum, though, and it gets filtered out through the kidney, you'll see that, in particular, in order to help get rid of more calcium and phosphate, again, you'll see calcitonin having positive effects here to influence more calcium and phosphate from being released. And then you'll have vitamin D and also parathyroid hormone will have inhibitory effects here. So by having these around, you're actually going to have more reabsorption of calcium and phosphate, and thus you're going to have higher serum levels of both, right? So it's important to remember the effects that the different hormones have in helping to maintain this homeostasis. Again, looking here in how vitamin D is going to be processed, remember that the skin's going to produce some degree of vitamin D3. Again, that's going to be just from exposure to UV rays. You also have D3, D and D2 being taken from the diet as well. Remember, these are not the active forms, right? It undergoes a two-step process in order to become activated. So once it's in the plasma, it goes to the liver, so we get that 25-hydroxy vitamin D. Again, still not active. So some of them might get eliminated, but the rest of it needs to go through the renal mitochondria, and then you get this 125-dihydroxy vitamin D. This is the active form. This is going to be the calcitriol that is going to be active and good for patients who have significant renal dysfunction. So it's important to remember, if I have a patient who has hepatic dysfunction, which vitamin D products I can give him or her, or if I have a patient who has a renal impairment, which ones are going to be effective for him or her based on what they are able to activate with, right? So just remember the different products there, what effects they're going to be having. You'll also see that when you have vitamin D, this is going to have kind of a negative effect, inhibitory effect on the parathyroid hormone, because once you have enough vitamin D, and also calcium is going to be important for this as well, but once the parathyroid gets that signal, it's going to say, hey, I probably don't need to release any more parathyroid hormone. Things are kind of at a good level. I can kind of stop releasing this, since I don't have to do things like resorb more bone and whatnot. So again here, just a slide that kind of shows the relationships between things like calcitonin and vitamin D and parathyroid hormone and their effects on increasing the amount of calcium being either absorbed or eliminated within the body. Again, remember here, it's going to have a stimulatory effect if it has this kind of lightning bolt pattern, and if it has this kind of stop pattern here, it's going to be more of an inhibition, right? So just starting here on the left side of the slide, when you have increased levels of calcium in the serum, you're going to be seeing that it's going to have an inhibitory effect on producing more parathyroid hormone, right? Ways to increase the release of parathyroid hormone is going to be by decreasing the amount of calcium that's there, right? So decreasing the amount of calcium in the serum is going to help to stimulate the parathyroid to release parathyroid hormone. And then also the help of vitamin D, you're going to be seeing increased absorption of calcium from the intestine, increased reabsorption in the kidneys, and then also increased uptake from the bone itself, all of which will help to increase serum calcium levels. And then when you have increased serum calcium levels, you're also going to be seeing stimulatory effects on these C cells, which are basically going to be releasing calcitonin. And calcitonin is going to have an inhibitory effect on calcium. You're going to be seeing less of it being taken up from the bone and potentially more of it being released inhibiting basically the reabsorption of calcium from the kidneys, and so you're going to end up having a lower amount of calcium. And again, when you have a lowered serum calcium, this is going to have an inhibitory effect on releasing more calcitonin. So I had a question from one of the students. Basically, it came down to, I'm kind of confused about the calciferols. Their question was, I thought it was used to treat low levels of calcium, like it says it's used to treat hypocalcemia due to hypoparathyroidism. But they also say its mechanism of action is to decrease parathyroid hormone levels. Why would it decrease parathyroid hormone levels if you need more calcium? Wouldn't it increase the levels? So kind of getting back to what we were talking about, essentially you're going to see that calcium and vitamin D both have inhibitory effects on the parathyroid hormone, or on release of parathyroid hormone. Essentially, when you're the parathyroid is in there kind of monitoring vitamin D levels and monitoring calcium levels. When either of those drop, they kind of have that signal to say, hey, we need to increase the amount of calcium in the serum. I'm going to go ahead and start to release more parathyroid hormone. It also helps to increase uptake of vitamin D from the gut. And so by doing that, you're going to be seeing that the response is more vitamin D activity, hopefully if you're able to process it in the liver and in the kidneys, and more calcium absorption. Once you have more vitamin D levels, which should be increasing your calcium levels, and once those calcium levels come up, both of those are going to have an inhibitory effect on the parathyroid gland. You kind of see this with paracalcitol, which is utilized in patients with renal disease who have a secondary hyperparathyroidism, in which they're having that renal osteomalacia occur, or renal osteodystrophy occur, where they're having too much bone being reabsorbed, basically because they have this increased parathyroid hormone, because they're not able to make their own vitamin D, and also because their calcium levels are being taken down by their phosphate. So because of that, you can give paracalcitol or Zemplar, and that will actually kind of activate the parathyroid gland, because it's acting like vitamin D, and say, hey, let's stop releasing more parathyroid hormone and kind of limit that. So calciferols have an inhibitory effect on the parathyroid gland to inhibit release of parathyroid hormone, because it's getting the signal, once I have enough vitamin D, once I have enough calcium, I really don't need to release anymore because I'm at a homeostatic kind of level. So hopefully that clears it up. If not, go ahead and send me another email and I can be happy to kind of go through it in more detail. So here we have our bisphosphonates. Just remember the medications that work in this category. Basically, big uses here are to inhibit bone resorption. Certainly if you have things like hypercalcemia, this can be useful for that as well. But osteoporosis is where you're going to see the most use for these drugs. Just keep in mind some of the administration kind of troubles you run into. Really depends on patients for taking oral dosage forms that need to be able to sit upright and for at least 30 minutes. Because if this gets caught in the esophagus, you can definitely have some esophageal irritation, potentially even some ulcers form, hopefully not perforations. I don't know if that's ever been reported in literature, but certainly it's a possibility. So all those reasons, if you have a patient who cannot tolerate taking this orally, certainly you can give it IV. We have certain varieties, things like zoledronic acid or pamidronate, are all able to be utilized very infrequently IV. So some of them you'll see given every few months. Zoledronic acid, I believe, you give every year. So those are all things that can kind of help increase the tolerability by your patients. So good things to remember about the bisphosphonates. So moving on and talking about our thyroid gland, it's important to remember the different steps here in the actual production of thyroid hormone, to know things like the differences between T4 and T3, and also to have an idea of the effect of iodide on the production of thyroid hormone. So keep in mind that when you have iodide being brought in, at normal levels, say, at normal recommended daily intakes, this is going to have a stimulatory effect on the production of thyroid hormone. However, if you have too high levels of iodide, so say you're taking kind of super therapeutic doses, this will actually have an inhibitory effect. So you end up having too much iodide around, it's going to inhibit this whole process, and so you can actually utilize that for things like dealing with goiters or shrinking the thyroid gland down prior to either radiation or resection. So iodide, it can either have a stimulatory effect at lower levels or an inhibitory effect at higher levels. But once you have this process here, once you have it getting converted over to iodine, it gets converted over to this monoiodotyrosine or diiodotyrosine. There, they can be kind of connected together to make either T4 or T3. Obviously, it's good to remember that your T3 is going to be your active form, and T4 is going to be the inactive form. So when we look at your different drugs to mimic the effects of thyroid hormone, it's important to remember that which drugs are going to be working most quickly. So obviously things that have a higher concentration of T3 are going to be much more active up front versus things like levothyroxine, which is the most common formulation used, has a higher ratio of T4 to T3. So it takes a few days, up to a week, before you really start to see the therapeutic effects, because that conversion from T4 to T3 does take a while, right? So again, it's important to remember the differences there, and why we have a delay in action with some of these drugs versus some that work much more quickly. It's also good to remember your antithyroid drugs, so in particular your propylthiouracil or PTU, and then also your methimazole. Obviously, they're going to be a good thing for things like Graves' disease, where you have too much thyroid hormone activity. So by giving this, you're going to be preventing the production of more thyroid hormone. So keep in mind that the duration or the onset of action, again, is going to take a while, because if you already have a high amount of T3 that's available in the bloodstream, this is only going to inhibit the effects of producing more thyroid hormone as opposed to dealing with the stuff that's already active. So keep in mind that, again, onset of action is going to be fairly delayed with these ones as well. Moving on, we're going to talk about the old kidney beans here. Again, looking at the different types of acute kidney injury, it's important to kind of evaluate the patient and try to determine what type of renal injury you're talking about. Again, three major types are going to be your pre-renal, your intrinsic, and your post-renal. Keep in mind that we have certain drugs that are going to be causing one or the other. Some of them will cause multiple types, right? So when you're thinking your pre-renal acute kidney injury, you're thinking about things that are decreasing perfusion with hopefully undamaged parenchymal tissue. Obviously, if you're hyperperfusing the kidneys for long enough, you're going to have that parenchymal tissue, so it can't become an intrinsic effect. But think about things that are decreasing renal blood flow. So things in your mind should be things like ACE inhibitors, angiotensin receptor blockers, certainly things like your NSAIDs, or just things that are depleting fluid volume. So if you're having excessive vomiting or diarrhea, all those things can decrease the amount of volume getting to the kidneys. Intrinsic kidney disease, we're going to see more for things that have direct toxic effects. So certainly if we have things like our aminoglycosides are going to be a big one, or amphotericin B or cisplatin and things like that, all are going to have more of an intrinsic effect. And then your post-renal is going to be more of an obstructive outflow issue. So certainly things that are going to crystallize out, so things like methotrexate or acyclovir are going to be seen to cause more of your post-renal effects than anything else. Looking at your the differences in your GFR and your serum creatinine that occur once you have an acute kidney injury. This is really important here because you can't always take the patient's GFR to be the gospel here. Notice that in the top part of the graph, you see that when the insult initially occurs, you see an immediate decrease in your GFR. However, it takes time for that serum creatinine to really build up to a new steady state. And so because of that, your serum creatinine are really going to lag behind by 1 to 2 days. So if you're already seeing a bump in your serum creatinine, you're kind of already behind the 8 ball to some degree, which is why it's really important to look at things like, looking at increases in your or looking at decreases in urine output. Certainly, if you see like a big drop in that over several hours, that can be a good indicator of, hey, something's going on here. You need to watch the patients a little bit more closely. So just keep in mind the limitations of using things like your Cockcroft galt or other creatinine clearance calculations, because they can be a little misleading in the short term. Getting a little bit back into drug-induced kidney injury, specifically, just wanted to look at some of the more common causes for that. So again, we talked a lot about things like our aminoglycosides, we talked about contrast-induced nephropathy, you talked about cisplatin, amphotericin. Those are probably going to be your most common ones that you're going to be seeing, causing an acute tubular necrosis. Remember, we talked more about in details on the ways we can help to prevent that drug-induced kidney injury from occurring. So if you remember things like aminoglycosides, remember that they are a concentration-dependent killer. So if I can give higher peaks of that, perhaps I can give it less frequently, and thus lead to less accumulation of the drug. So that's exactly what we see. By giving once daily dosing of aminoglycosides like gentamicin or tobramycin, you end up preventing those really high troughs from developing, and those high troughs, that accumulation, is what leads to the kidney injury that occurs there. So, and then doing your therapeutic drug monitoring as well to help make sure those levels are kept in check. Talked a lot about the radiographic contrast media. Certainly tanking them up with fluids beforehand can be effective, and for those high-risk patients, things like N-acetylcysteine or mucomist can be useful to help prevent that damage from occurring in the first place. Look at things like cisplatin. We talked about hydration being super important there. Certainly, amifostine is going to be a good drug that helps to prevent some of the damage that happens there. And then with amphotericin B, of things like liposomal preparations, also running the drug slowly, giving lots of fluids, things like that, all help to prevent some of the kidney injury that occurs there. So again, just remember your general strategies, and remember some drug-specific ones as ways to help prevent drug-induced kidney injury. It should be good for testing purposes. One of the questions that came up here was, for the treatment of acute kidney injury, there's lots of methods, some pharmacological, some non-pharmacologic, and I'm a little confused as to the indications for each of the treatments. Say, when to use a loop diuretic versus mannitol. Is it possible to clarify when to use each type of therapy? The big thing here is if you can prevent acute kidney injury, that's going to be the best thing for them, right? So prevention is the name of the game here. So when you have things like, say, contrast-induced nephropathy, if you're looking to prevent that, you want to do things like, one, eliminating nephrotoxins beforehand. So certainly, things like make sure the patient's not on metformin for some period of time before getting the contrast, to make sure they're not going to end up accumulating that drug to cause issues. Or looking at things like your aminoglycosides, make sure that the levels or the troughs are not too high, and you're going to accumulate that and potentially leave yourself more prone to having acute kidney injury. Really, the thing I was trying to point out with things like loop diuretics and mannitol, just because you're increasing the amount of blood flow going to the kidneys does not necessarily mean you're going to have a whole lot of beneficial effects here. So really, there's not a great way to treat the acute kidney injury. There's some ways you can definitely increase your blood flow, but again, if you're having an intrinsic injury, it doesn't necessarily make your kidneys work any better, it just increases the amount of fluid that's going through. So while your numbers, like your urine output looks better, they might not be able to, manage their electrolytes or, process waste as they should normally. So big things though are prevention. So again, really hydrating the patient well prior to giving a nephrotoxic medication is very important, especially for things like chemotherapeutic drugs that are going to inhibit are going to be nephrotoxic, or contrast agents, things like that. And certainly the only real thing that you can see maybe some preventative effect from is going to be N-acetylcysteine, and you can utilize that for some high-risk patients that you're really worried about acute kidney injury for. Potentially you can use that as a kind of an antioxidant to prevent damage from occurring. So I've seen that most commonly in patients who have existing renal disease that really need to get a CT for whatever condition they have, and so in order to help prevent any further damage from getting contrast, I went ahead and gave a day's worth of mucomist beforehand, or N-acetylcysteine, and then gave a day's worth afterwards in order to help prevent any injury from occurring. Another question, I'm also a little confused on slide 42 of the same lecture about electrolyte management of acute kidney injury. Is this slide talking about the implications of electrolyte imbalance in acute kidney injury, or is it talking about the actual treatment of electrolyte imbalance? Well, I would say a little bit of column A and a little bit of column B. I'll go to the slide now just to kind of talk a little bit more about that. To go along with the chronic kidney disease, you also see that erythropoiesis is going to be inhibited here. So again, this is where drugs like our epoetin or darbepoetin are going to be utilized to help our patients produce their own red blood cells, as opposed to having to give like a transfusion. Remember though, because we are increasing the hemoglobin concentrations, that can kind of cause more sludging of the blood. So you worry about increased risk of death, MI, stroke. And it's really important that we don't want to increase our hemoglobin levels too high. So again, looking at, when they gave too much epoetin to these patients and they're getting their hemoglobins above 13, they actually ended up seeing this increased risk of death and MI and stroke. So because of that, they had a black box warning. And so really, it's important to remember not to get our hemoglobin concentrations too high, because otherwise you run that risk. So here's a slide in question. So it talks both about the electrolyte shifts that can occur when you have an acute kidney injury, and then also how we can kind of treat some of those. So say for instance you have an acute kidney injury, you have kind of an impaired filtering process there. So one of the things you can end up seeing is that hypernatremia and fluid retention are fairly common. So how do we treat that? Well, we can do things like limiting the sodium intake. Makes sense. And then also potentially you can end up seeing some loop diuretic failure, in which case, we talked a little bit about ways to manage that. You can do things like try adding on a thiazide diuretic, and that helps to kind of deal with some of that loop resistance you can end up seeing over time. Again, big shifts in electrolytes are able to be mitigated by renal replacement therapy. So certainly if you had acute kidney injury, say an acute kidney failure, and you were having hyperkalemia and things like that, the effects of renal replacement therapy like hemodialysis are able to help kind of pull that off and get you back down to like a normal amount of serum potassium. Two things that are not really that well removed are going to be phosphorus and magnesium. So because of that, especially if you have patients who have trauma, or they're having rhabdomyolysis, which is a muscle breakdown, or tumor lysis syndrome, which is something you see especially for leukemias after you give them chemotherapy. Those things are not able to be pulled off quite so well. So what are some of the preventative things we can do is things like avoiding calcium. We've talked a lot about calcium and phosphorus being able to kind of bind to one another. And so by avoiding calcium, you can avoid precipitating out that phosphorus that may not be able to be pulled off. And then the other thing you can see after you give a patient renal replacement therapy is actually the potential for hypocalcemia. Because again, in order to prevent the blood from clotting off within the dialysis circuit, you can give a product called sodium citrate, or sodium citrate is probably the more common one, but that's able to help bind up calcium in the blood. And by doing that, you prevent the clotting cascade from kicking off. If you guys go back to your slides, you'll see that calcium is very important for initiating the clotting cascade. So by giving that citrate, you kind of bind up a lot of the serum calcium that's within the blood in the dialysis circuit. When you put it back in the patient, they can develop hypocalcemia. So very often you have to end up replacing that exogenously in order to help keep them at a normal level. So here, this is kind of getting from the acute kidney injury over to the chronic kidney disease. Just talk a little bit more about kind of the pathogenesis behind that renal osteodystrophy. Again, a lot of the issues end up coming from the initial impairment of the phosphate excretion. So again, so you're going to be retaining a lot more phosphate. And so that's going to be increasing your calcium phosphate product. It's going to lead to that calcification or precipitation of the calcium phosphate happening there. But not only that, you're having impaired production of that 125 dihydroxy vitamin D, which again is an active form, right? So if your kidneys aren't being metabolically active, they're not going to be producing that vitamin D. So because of that, your problems with increasing calcium absorption are going to be worsened. You're going to have increased parathyroid hormone. So you can see it's kind of a vicious cycle. So really the big things we're going to be seeing here is that providing more calcium and vitamin D in the active form is going to be necessary to help kind of restore that normal balance. And then we're also going to be focusing a lot on phosphate binders. So again, a lot of our antacids can help to work as a phosphate binder, but remember things like aluminum can be an issue, especially if you have impaired excretion of it. You can see a lot of mental status changes and things like that, and neurotoxicity if you have accumulation of that aluminum. So things like the amphogel, the aluminum hydroxide, can be problematic chronically, but it could be good, up front as kind of a quick way to help get that the phosphate levels down. So again here, just a good slide kind of showing the different phosphate binders that are here. One other thing that I did not mention just in the last slide is that it's important to remember that if you're going to be providing your patients with any kind of erythropoiesis stimulating agents, they really need to have iron on board. They need to keep their iron stores up, otherwise they're not going to be able to produce really any more hemoglobin. So it's really important to make sure they're topped off on that. Again, here looking at our different products, obviously there's going to be range in price for these agents. Calcium products are going to be a lot cheaper, but may not always be as effective, especially if say they already have, like say, hypercalcemia going on. So that's where things like your sevelamer and lanthanum kind of come in. Other things to remember, that ways to inhibit phosphate absorption is just to decrease the amount of phosphate that's being taken in by the patient. So certainly decreasing the amount of protein in the patient's diet can be very useful for doing that. So it's another kind of strategy, non-pharmacologic strategy, to get those phosphate levels down. So continuing on talking about things related to the kidneys, looking at sodium and water homeostasis, just wanted to compare the different crystalloids that we have available as kind of standard treatment for intravascular repletion for our patients. So again, looking at your different types of fluids, looking at what their salt content is going to be affecting what their free water amount is, and where the majority of their fluid is going to end up based on their tonicity, whether it's going to be more in the extracellular fluid or more in the intracellular fluid. So looking at things like D5, because it really has no solutes in it besides just the dextrose, no sodium, no chloride, it's very hypotonic for the most part, so you're going to be seeing much more of it kind of shifting into the intracellular fluid. So free water wise, you have about 1,000 mLs for every liter there. That's composed of things like, or as compared to things like half normal saline at 0.45% saline. There it's about 77 milliequivalents of both sodium and chloride. Still hypotonic, because again, your osmolarity there is only about 154 total. Normal serum osmolarity is around 280 or so, 290. You're going to see more of it's retained within the extracellular fluids in the intravascular space. And a smaller amount is going to be going to the intracellular fluid as compared to something like D5. So maybe only half a liter of free water there. But looking at isotonic solutions, things like Ringer's lactate or 0.9% normal saline, you see there it's much closer to the normal amount of solute that you see in the blood. So because of that, has relatively no free water, and almost all of that's going to be staying within the extracellular space. Right, and then if you look at 3% sodium chloride, it has very, very high concentration, very hypertonic, and so this actually has a negative amount of free water associated with it, because this will actually help to draw fluid out of the intracellular space into the extracellular space. So say for instance you have a patient who has cerebral edema, they have a lot of fluid going on in the brain. You can give hypertonic saline, because that actually is going to pull the fluid out from behind the blood-brain barrier and help to decrease some of that swelling that happens there. So that's a lot of times where you'll see hypertonic saline being used for that purpose. So looking at hyponatremia, again, it's important to kind of determine what the serum osmolality is, and then based on that, you have a little bit better idea of the etiologies there. Again, the most common one you're probably going to see is going to be the low serum osmolality hyponatremia or hypotonic hyponatremia. You certainly can see it with hypertonic hyponatremia, especially if you have patients who have very high blood glucose levels. So certainly patients who potentially are DKA or HHS, that would be someone who has very high glucose levels, and what that's going to do is actually end up leading to the patient having a shift of sodium based on the solute concentration where the water is going to go, where actually the sugars are going to be causing more water to come from the intracellular fluid to the extracellular space and kind of dilute out the sodium you have there. So that's where you get this kind of hypertonic hyponatremia that's developing there, because basically the water is just diluting out the sodium you have. But again, more commonly you're going to see hypotonic hyponatremia, and based on that you kind of need to figure out what their volume status is. So say for instance that they have hypovolemic or they're fluid depleted, of hyponatremia, a lot of times you're going to see that's related to things like, just fluid loss. So if you have things like, GI losses, vomiting, diarrhea, skin or lung losses, and you see issues with like things like diuretic abuse and whatnot. So those are, we'll talk more about treating that in a second, but those would be the typical causes for hypovolemic hyponatremia. Look at the hypervolemic hypernatremia. This is where you end up having a lot of issues with fluid retention. So certainly if you have cirrhosis or CHF, anytime you're having impaired cardiac output or impaired flow, venous flow, you can have this. Nephrosis can be another cause as well. So those are typically going to be just fluid overload for the most part. And then looking at the euvolemic, this is where we get more into drug therapy, but certainly this is where we can see things like SIADH being one of the primary causes for this euvolemic hyponatremia. So just looking at the different types of volume status, again, trying to determine what type of etiology might be responsible for your hyponatremia is very important to be able to determine. Again, for the euvolemic hypotonic hyponatremia, again, because this has kind of the most drug therapy associated with it, I'll probably focus on this the most. But again, drug-induced SIADH, or that syndrome of inappropriate antidiuretic hormone release, can be due to a number of different things. Certainly, you can have increased release of the hormone. So we see things like TCAs, nicotine, zinc alkaloids, all of these things can be responsible for increasing antidiuretic hormone release. But then certain drugs can increase the sensitivity to the ADH you're already releasing. So things like carbamazepine, lamotrigine, certain NSAIDs potentially. And then you'll have things which will have some mixed action. So like MDMA or methylene dioxymethamphetamine, ecstasy, some ACE inhibitors or SSRIs can all be responsible as well. Again, they're going to have a little bit of both activities of both increasing release and increasing sensitivity. One of the big things to focus on the hyponatremia side is that obviously, there's a lot of significant neurologic consequences that come about from having too low of serum sodium. But correcting this too quickly, especially for patients who have had a longer amount of time to kind of equilibrate, again, because when you have patients who have more of a chronic hyponatremia, what's going to end up happening there is you're going to have more fluid that's going to be kind of accumulating within the CNS. So if I correct that too quickly, if I bring that sodium up too high, too fast, you're going to end up having a lot of fluid coming out of the brain. And then you're going to be causing this osmotic demyelination syndrome, right? And this can be definitely fatal, definitely a huge sentinel event occurring within the hospitals. So something you definitely want to avoid if ever possible. So it's important to know just how quickly you can correct the sodium without getting yourself into trouble. So again, I probably won't have you guys do any calculations for the test, but just be aware of some of the concepts that are going to be here, and that how you determine how quickly to be able to change someone's serum sodium and how you calculate that. So again, the things you want to know are what's your goal to be able to change someone's serum sodium. Again, you don't want to go faster than 12 milliequivalents per liter in the first 24 hours. Kind of goes out the window if the patient's acutely decompensating or they're seizing, they come back and their sodium say 119 or something. That needs to be corrected immediately. So you'll do some boluses of hypertonic saline, like 3%, in order to help stop their seizures or whatever their the decompensation is. But then after that, then you want to focus on changing the rest of that 12 milliequivalents in the first 24 hours. So again, looking at the calculation here, you're looking at what basically a liter of whatever IV solution you're looking at, added to their patient's total body water. What kind of change in serum sodium is that going to be? So again, you're looking at the change in sodium is going to equal the amount of sodium in the IV you're giving minus the sodium that's in their serum. So again, if it was a hypertonic saline like 3%, you have 514 milliequivalents per liter minus, say, the patient's 125 milliequivalents per liter. You'd be dividing that out by their total body water. Again, total body water is going to be their weight times 0.6 for men and 0.5 for women, and then adding that to the 1 liter of IV solution that you're giving. So based on that, you're going to be able to figure out how much, if I give 1 liter to this patient, how much that's going to change their serum sodium. And so based on that, then you can figure out, well, okay, how much of obviously you may not need to give a liter, maybe I need to give less than that to get that change. But the 12 milliequivalents per liter in that first 24 hours is going to be the key there. Especially the longer they've had hyponatremia kind of festering, the more careful you have to be in changing that serum sodium. Again, if they are non-emergent hypovolemic hypotonic hyponatremia, again, you typically want to end up using normal saline, right? Because if I'm using hypertonic saline at 3%, I run the risk of really correcting them too quickly, which again can lead to that osmotic demyelination. And these are patients who are volume depleted, so by giving normal saline or at 0.9%, 154 milliequivalents per liter of sodium, I'm able to not overcorrect them too quickly and able to help replenish that volume as well, right? So here for your non-emergent euvolemic hypotonic hyponatremia, again, this is most often going to be your SIDH. One of the big things you need to do is discontinue any of the offending drugs that might be present. So, if they're on carbamazepine to develop this, again, just take them off the med and move them to something else if possible. And then you really need to restrict their water intake, so maybe only like a liter to 1.2 liters per day. And then what you end up usually doing is giving sodium chloride tablets and/or a loop diuretic. Basically, by increasing the solute intake and augmenting the amount of water that you're excreting, you can help to restore that to where the volume will usually remain somewhat euvolemic, maybe a little hypovolemic, but it helps to bring up the serum sodium concentrations pretty well. The other drugs that we can potentially use are going to be our tetracycline derivative methylcycline. Again, remember some of the contraindications for that. Certainly, though, this can induce a diabetes insipidus, which again is going to be kind of the opposite of what this SIDH is. And so basically by doing that, you're preventing the ADH activity there within the kidney itself. And then the other drugs would be our vasopressin receptor antagonists, so basically just inhibiting the effects of ADH within the kidneys as well. And then for your hypervolemic hypotonic hyponatremia, here you basically need to have them have a negative water balance while trying to minimize their intracellular volume as much as possible. So typically by limiting their fluid intake and their sodium intake, you can end up especially if potentially you have like a loop diuretic on board to help get rid of some of that extra volume. But really the big thing is you need to improve their contractility. So whether it be digoxin, which can help with that, or using things like ACE inhibitors or ARBs for afterload reduction, that's going to be more effective in increasing that contractility and helping to kind of pump off that extra volume. So we had another student question here, and they asked, is normal saline the best fluid replacement for a patient in shock? Or does 3% saline work better or just as well with 100% of that fluid staying in the ECF to replenish volume in the intravascular space? Essentially, normal saline is the best fluid for a patient in shock. Essentially, what that shock means is that their intravascular volume, not the intracellular fluid, but the actual intravascular volume within the systemic circulation is low, right? They do not have enough volume within the vessels in order to provide oxygen to all the tissues they need to. So by giving normal saline, you're giving an isotonic fluid, which is pretty close to the normal serum sodium. Normal serum sodium is anywhere between 135 and 145. Normal saline has about 154 milliequivalents of sodium per liter, so it's relatively close to normal. You're very rarely, if ever, going to cause a hypernatremia by giving normal saline. I've never actually seen that happen. I don't think it really would, just based on your kidney's ability to compensate for that. The problem though, if I give hypertonic saline, if I give 3% normal saline, what that basically does is it gives very concentrated sodium concentration in a smaller volume. So you're looking at the actual sodium concentrations. 3% saline is going to be about 3 times, a little over 3 times as much sodium per volume than the normal saline is. So I'm giving less volume just to get the same amount of sodium, so that doesn't really do much to increase my intravascular volume. But what that can do is actually draw fluid outside of from the intracellular fluid to the extracellular fluid. That doesn't really do me any good because then I'm just kind of depriving fluid from my tissues. Really, normal saline and lots of it is going to be best for our patients who are in shock. And then for another question, for a patient with diarrhea who is depleted intracellularly, you stated that 0.45% or half normal saline is a good choice. can D5 be used also since a high percentage moves to the intracellular fluid space? So typically what you end up seeing with a patient with diarrhea is kind of similar to what we talked about with that shocky patient. So essentially their intravascular fluid is depleted, so the actual fluid within the blood vessels themselves. Their actual intracellular fluid itself is not necessarily as depleted as it just is the intravascular space. So it's important to keep in mind the difference there. So because of that, if I give all that free water, if I were just to give D5, really none of that is going to stay within the intravascular space where I kind of want it to be, right? So by giving 0.45% or half normal saline, I can keep a higher percentage of that there, so it's a little bit better balance between where I'm putting the fluid. So part of it's going to stay in the extracellular space or in the vessels, and then a little bit of it, more of it's going to go to the extracellular or the intracellular space within the tissues itself. So again, by giving the half normal saline, you get a little bit better balance. You keep more of it in the intravascular space where it can be useful there as well. So half normal saline, most often if I see a patient who has significant diarrhea, you'll see them being put on D5 half normal saline. It's a very, very common fluid to give, where they have the dextrose, so it can be good for, especially they haven't had good PO intake. Maybe they're having issues with their blood sugar, and then you had the sodium in there as well to help keep a little bit better balance on where the fluid's going to go. So D5 half normal saline, usually with like 20 milliequivalents per liter of potassium, is a very common kind of maintenance fluid that a lot of patients will be on. You'll see a patient get kind of hammered with normal saline up front, and then they'll get put on maintenance fluids. Usually D5 half is a very common one. Okay, then moving on, talking about rapid sequence intubation. We covered a lot of different drugs in this group. Just keep in mind, like, what are the different drugs that we have in this category? What are the circumstances where I give one versus another? And know the differences in mechanism. So specifically, if I'm talking about ketamine versus etomidate, know that they're both sedatives, but they're going to cause their mechanisms. They're going to cause their sedation via different mechanisms. It's important to keep those in mind. Remember the order that you're going to be using the drugs. So specifically, if I ask a question about what order do you want to give these medications, you don't want to put the paralytic first, right? Because you don't want to paralyze anyone who doesn't have any sedation on board. So keep the order in mind. And then be aware of kind of the pros and cons of each agent. Remember things like contraindications for drugs like succinylcholine, probably be one of the biggest ones. Other things to keep in mind, the differences in mechanism would be between your depolarizing and non-depolarizing neuromuscular blockers are going to be the big things there. And then when we talked about the ACLS drugs, the different medications to cover, just remember in which circumstances I'm going to be giving these. Might be important to remember which ones can be given down the endotracheal tube. Again, remember there's a little mnemonic to remember that one. And just remember when drugs might be effective in one type of situation versus another. So, if I have an opioid overdose, what's going to be my agent that blocks the effects of those opioids? Probably going to be naloxone. If I have a hypoglycemic patient, probably going to be dextrose I'm going to give there. Obviously, epinephrine is going to be really good for either for bradycardia or tachycardia, so especially VTAC, VFib, or if you're just in asystole or PEA, epi is going to be the drug to go to. But remember that for bradycardia, atropine is actually your first line, and then epi can be used as kind of a backup. So little caveats to remember there. Just remember kind of where each drug is going to be utilized and some of the adverse effects associated with them as well, if we talked about it. And then we talked about hyperkalemia. So again, the mnemonic here is going to be that CA big K drop. So those are the different agents that can be utilized to treat hyperkalemia. Just remember the different mechanisms for how these are going to be utilized to treat hyperkalemia. So remember that calcium, it doesn't get rid of extra potassium in the body, right? It's going to be utilized to help stabilize that myocardium. Know which ones are going to be driving potassium intracellularly. Know which therapies are going to be able to pull potassium off the body. Those are all good things to remember. Again, there's not necessarily a specific order. I know that question had come up previously about, which one do I give first? I'll tell you, a lot of it has to do with what kind of type of access you have on the patient. So, if I have a patient who's coming in via EMS and their potassium comes back at 7 and they're starting to have PVCs, I need to start treating them, but they don't have an IV available, then I can start by utilizing albuterol, right? I can just put a nebulizer on them and start treating them that way. Albuterol is probably the weakest one out of this whole group, but certainly it's better than nothing. Once they have IV access, then you can start to worry about giving the other drugs. And so a lot of these are going to be given kind of in concert, to where you'll be given the bicarb, the insulin, the glucose, pretty close in succession. So again, all of it depends on your access. And then we talked about anaphylaxis treatment. Just remember kind of what your common players are going to be, things like your H1 antagonist, your H2 antagonist, and then how we're going to be administering some of these guys. Also important to remember the kind of onsets of action, which ones are going to be working most quickly versus which ones are going to be working a little bit more slowly. Certainly, remember corticosteroids are going to be taking the most time to work, since they have to get down to that, they're affecting gene transcription and things like that. But then epinephrine is going to be kind of your go-to drug for true anaphylaxis. Again, keep in mind the type of dosing that we're going to be utilizing here. Mostly you're going to be giving epi-IM in cases of anaphylaxis, unless it's very, very severe, in which case you may give it IV. Keep in mind that the concentration of epinephrine is also going to matter as well. For utilizing epinephrine in like code type situations, you're utilizing the medication in a concentration of 1 to 10,000, which means you're going to have 1 milligram for every 10 mLs, or there's 0.1 milligrams per ml of epinephrine. By using that more dilute concentration IV, you can kind of titrate your dose a little bit better, versus when you're giving a drug intramuscularly, you want smaller volumes. So for like epinephrine to give it IM, you'd want to use a more concentrated form, to where you use the 1 to 1,000 concentration, which is 1 milligram per ml. So again, for a full-grown patient, it might be utilizing only half an ml of IM epinephrine versus 5 mLs of IM epinephrine. Obviously, 5 mLs is way too much volume to be giving intramuscularly. So again, concentration is very important here. And then as far as geriatrics go, again, probably the smallest amount of material comes from this lecture, just because it's a little bit less material intensive. You'll see things about changes in physiologic processes as age goes on. It's really important on how we're going to be assessing organ function. So kind of remember some of the caveats we talked about with the Cockcroft-Gault equation, and how measuring GFR, measuring creatinine clearance in these patients may not always be successfully done with the Cockcroft-Gault. You may need to use different calculations in order to get an accurate assessment of their renal function. And remember how their creatinine is going to change over time. So little old ladies are not going to have as much muscle mass to produce creatinine as a younger patient, or if they've had an amputation and things like that. Also remember medications to avoid in our patients, so certainly things that have long half-lives or active metabolites, especially with CNS drugs. So remember the things like benzodiazepines that are effective for these patients, and things that might be, may stick around for a longer period of time and lead to oversedation. And then our therapies for dementia as well. Keep in mind though that looking at dementia in elderly patients, you want to look at other causes as well. Do they have a UTI? Is there medications that's changing their mental status? And focus on those first before jumping to adding on more medications to treat these geriatric patients. So anywho, so that's material for the test. Again, if you have any questions, I believe we'll have an opportunity to talk about it on Monday. Monday I'll be starting up the new section. So again, anything before, try to answer questions as close to the test as possible, but be mindful that the sooner you get them in, the more likely they are to be answered. All right, thanks for listening, and I will see you guys on Monday.